Welcome to The Deep Dive, the show where we unpack complex topics and arm you with the essential insights you need to be truly well-informed. Today, we're plunging into a marvel of human engineering, a joint that really epitomizes both extraordinary power and, well, surprising fragility: the shoulder.
It really is quite something, isn't it?
It's an incredible feat of anatomy, capable of immense force and delicate precision, yet paradoxically, it's also one of the most inherently unstable joints in the human body. So how does this fundamental conflict play out, particularly in the demanding, high-stakes world of professional athletics, where every movement is pushed to its absolute limit?
It's truly a fascinating paradox that incredible range of motion often comes at a cost, making the shoulder a frequent site of injury in sports, as you know.
Indeed, and that's precisely why we're taking an in-depth look today. This deep dive is an exploration into the intricate world of sports-related shoulder injuries. Our aim is to provide mid-senior medical professionals like you with practical, evidence-based insights that hopefully transcend basic understanding, giving you that critical edge in diagnosis and management. And joining me today to navigate this complex landscape is a truly distinguished expert in the field, Professor Mo Imam. He possesses an exceptional ability to synthesize complex orthopedic information, draw critical connections between nuanced details, and truly illuminate the broader clinical implications of these injuries.
Thank you. It's a pleasure to be here and to delve into a topic that truly underpins so much of what we see in practice.
Our mission today is clear. We're going to meticulously unpack the shoulder's fundamental anatomy and biomechanics, dissect common injury patterns unique to athletic demands, and explore cutting-edge diagnostic approaches and evolving management strategies. Ultimately, we want to enhance your diagnostic precision and elevate the efficacy of your treatment plans, optimizing outcomes for your athletic patients. You know, when we talk about the shoulder, it's this incredible paradox capable of throwing a fastball at, 100 miles per hour, yet seemingly prone to dislocation just from falling awkwardly. What is it about its fundamental architecture with its 5 joints, 8 ligaments, and 30 muscles that creates this inherent conflict, offering unparalleled mobility at the cost of inherent instability?
That really is the core paradox, isn't it? The shoulder achieves its status as the most movable joint in the human body, precisely because it sacrifices inherent stability. Its primary function is to facilitate incredibly precise hand positioning in space, allowing for complex multi-directional movements. But this comes at the expense of a deep, bony socket, the kind that would provide intrinsic stability like you see in the hip, for instance.
Why? So it's a trade-off.
Exactly. And when we consider its movements, we're talking about a full spectrum: internal and external rotations, abduction and adduction in the frontal plane, and flexion and extension in the sagittal plane. The combination of these elementary movements generates circumduction, that complex circular trajectory we see, for example, in a pitcher's windup. Crucially, the glenohumeral joint also has significant translational capabilities: anterior-posterior, superior-inferior, and medial-lateral. All of this extensive range of motion is critically dependent on a balanced and synchronized interplay between both its static or passive and active or dynamic stabilizers. Without that delicate balance, the entire system falters.
Okay, so passive and active stabilizers working together. 1.2 static stabilizers, the passive framework. So if extreme mobility is paramount, what precisely is holding it all together? Let's delve into the static stabilizers first, starting with the bony components. What's truly fascinating about the bone geometry that contributes to this delicate, often precarious balance?
Well, the bony anatomy itself is a major contributor to the shoulder's inherent instability, actually. Take the humeral head, for instance. It exhibits significant variability in shape and size, and on average, it's retroverted by about 19 degrees, though there's quite a range. This retroversion, along with the humeral head's curvature, plays a role in how it articulates with the glenoid.
And the glenoid, that's the socket part, isn't it?
Yes, and it's remarkably shallow. It's pear-shaped, with an average depth of just 2.5 millimeters in the antero-posterior direction and maybe 9 millimeters inferiorly. This minimal bony containment, coupled with its slight retroversion and superior inclination, is a fundamental architectural compromise. It grants unparalleled mobility but forces the soft tissues to do the heavy lifting for stability.
So the bones offer very little constraint on their own.
Precisely.
Yeah.
What's even more astounding is that only a maximum of 30% of the humeral articular surface articulates with the glenoid at any given time. This starkly underscores the indispensable role of the soft tissue and dynamic restraints. When we consider how little bone-on-bone contact there is, it becomes clear why even subtle changes in bony anatomy can significantly influence stability.
Which brings us to bony lesions after trauma.
Exactly. Certain bony lesions often arise after traumatic events leading to instability. The bony Bankart lesion, for example, located at the anterior inferior glenoid rim, becomes clinically significant when it involves more than 20% of the glenoid's length, predisposing to recurrence. If it involves over 50% of the glenoid, shoulder stability is reduced by more than 30%.
And the classification for that?
Bigliani et al. Classified it into type 1, 2, and 3 based on displacement and healing. Then you have the Hill-Sachs lesion, a compression fracture at the posterolateral aspect of the humeral head that typically occurs following an anterior dislocation. And we also see reverse lesions, like the reverse bony Bankart lesion or the reverse Hill-Sachs, also called the McLaughlin lesion, on the anterior humeral head, which can become engaging during specific arm movements.
Right, engaging meaning it can catch on the glenoid rim.
Exactly.
Okay, beyond the intricate bony architecture, you mentioned the soft tissues play an equally crucial, if not more critical, role. What are these unsung heroes and how do their complex interconnections contribute to stability and, well, instability when injured?
You're right, the soft tissues are absolutely vital. A key concept here, especially for understanding instability, is the glenoid tract. Think of this as the contact area between the glenoid and humeral head. It shifts from the inferior medial to the posterolateral portion of the humeral head's posterior articular surface during maximum external rotation, extension, and abduction.
Okay, so the contact zone moves.
Precisely. And the glenoid tract's width is about 84% of the glenoid's width. This means that any glenoid articular surface loss, as we see in bony Bankart lesions, significantly influences this crucial dimension. Why this matters clinically? It precisely influences the risk of Hill-Sachs lesion engagement. If the humeral head bony loss remains within the glenoid tract, it's considered on track.
Meaning less risk.
Exactly. No possibility of the Hill-Sachs lesion overriding the glenoid rim. Conversely, if it extends over the medial margin of the glenoid tract, it's off track, and the risk of engagement rises significantly. This distinction is critical for surgical planning.
That makes sense. So what are the main soft tissue players?
Well, looking at the soft tissue stabilizers themselves, we have the glenoid labrum, the glenohumeral capsule, the glenohumeral ligaments, the rotator interval, negative intercapsular pressure, and the adhesion-cohesion mechanism. The glenoid labrum, that triangular fibrocartilaginous ring, is particularly prone to lesions. A Bankart tear, affecting the anteroinferior labrum, has a high association with recurrent instability, potentially up to an 87% recurrence after an arthroscopic Bankart procedure under certain conditions.
That's a huge recurrence rate.
It is. We also see the ALPSA interior labro-ligamentous periosteal sleeve avulsion, where the complex rolls up, displaced medially and inferiorly. This potentially carries an even higher risk of redislocation than undisplaced Bankart tears.
And the capsule and ligaments?
Also key. Capsular stretching is quite common in recurrent anterior instability, found in up to 28% of patients. Conversely, recurrent posterior subluxations lead to posterior capsular redundancy and increased joint volume, causing posterior instability. This redundancy, in various directions, is a very common finding in atraumatic multidirectional instability. The glenohumeral ligament superior, SGHL, middle, MGHL, and especially the inferior glenohumeral ligament complex, IGHLC, primarily act at the extremes of range of motion when they are in tension.
So not so much in the mid-range.
Correct. In the middle ranges, the rotator cuff and long head of biceps take over more. The IGHLC forms a crucial sling-like structure that moves anteriorly during abduction, external rotation, and extension to restrain anterior humeral head translation. An HEAGL lesion, humeral avulsion of the glenohumeral ligament, where the ligament pulls off the humerus, has an incidence as high as 10% and can often be missed.
So another potential hidden injury.
Yes. Then there's the rotator interval, that triangular space bounded by the coracoid, biceps tendon, subscapularis, and supraspinatus. It's an important inferior stabilizer. Insufficiency here can be clinically appreciated, especially in athletes when muscles are contracted. And finally, almost imperceptibly, you have mechanisms like negative intracapsular pressure, a sort of suction effect, and the adhesion-cohesion effect.
Like wet glass.
Exactly like wet glass surfaces sticking together. The articular cartilage surfaces create a subtle but critical bond through fluid-mediated mechanisms. This highlights how vital a healthy, intact cartilage surface is for maintaining that foundational stability, even before the muscles kick in. 1.3 dynamic stabilizers. The active control system.
Okay, so the static structures provide the foundational architecture, but the shoulder is anything but static. It's constantly in motion, performing incredible feats. That brings us to the active control system, doesn't it? How do the muscles and proprioception actively coordinate to keep the shoulder in check and enable its incredible mobility?
Precisely. The dynamic stabilizers are the real-time guardians, constantly adjusting, and their combined and synchronized roles are absolutely paramount in maintaining dynamic stability. The rotator cuff muscles are the primary dynamic stabilizers here. Their main function is to compress the humeral head onto the glenoid surface, centering it and dynamically tightening the capsule ligamentous structures they attach to. These four muscles, subscapularis, supraspinatus, infraspinatus, and teres minor, effectively hug the joint, creating that dynamic compression.
A hugging effect. I like that.
It's a good visual, and the work by Wolker and colleagues was quite compelling. They show that even a 50% decrease in rotator cuff muscle forces resulted in nearly a 50% increase in anterior displacement of the humeral head in response to external loading.
Wow, that really underscores their importance.
It does. It shows just how vital their active contribution is. The subscapularis in particular provides anterior stability, especially when the arm is in neutral rotation.
Now, you mentioned impingement earlier. Can you clarify the types we see?
Yes, within this dynamic system, we often differentiate between two primary types of impingement. External impingement is an abnormal contact between the coracoacromial arc, that's the roof of the shoulder, and superior surface of the rotator cuff. Internal impingement, on the other hand, involves abnormal contacts between the rotator cuff's articular surface, the underside, and the posterior superior glenoid rim. This is particularly common in throwing athletes.
And the cause of internal impingement is debated.
There's an ongoing discussion, yes. It's often attributed to anterior microinstability and tightness of the posterior capsule. Others highlight that posterior-inferior capsular contracture can result in posterior-superior instability, leading to a peelback of the superior labrum and rotator cuff tearing. It's likely multifactorial in many cases.
What about the biceps?
The long head of biceps acts as a secondary stabilizer. Its role becomes predominant and critical when a rotator cuff or capsular ligamentous deficiency coexists, which we often find in patients with insufficient rotator cuff function. Then we have the scapulothoracic muscles and their rhythm. The key scapular rotators include the trapezius, rhomboids, latissimus dorsi, serratus anterior, and levator scapulae. Codman's seminal concept of scapulothoracic rhythm describes the coordinated movement between the scapulothoracic joint, essentially a sliding surface between the scapula and the rib cage, and the glenohumeral joint.
So the shoulder blade has to move correctly with the arm.
Absolutely. The scapular rotators enable the glenoid to modify its orientation to follow the humeral head during motion. This is crucial. Dysfunction, such as weakness or imbalance in the serratus anterior, can predispose athletes to rotator cuff tendinitis or atraumatic shoulder instability. Therefore, recovering the scapulothoracic rhythm through appropriate rehabilitation of these scapular rotators is absolutely essential, particularly in younger patients.
And finally, proprioception, the subclave joint position.
Yes, proprioception. Numerous mechanoreceptors are located within the glenohumeral joint capsule, particularly concentrated in the anterior and inferior capsule. These are activated during movement, sending crucial signals to the stabilizing muscles. Here's the profound clinical implication. Progressive instability leads to increased capsular stretch and, consequently, proprioceptive loss or disorganization.
So the instability damages the feedback system.
Precisely. This disorganization can then lead to muscle patterning problems, repeated dislocations and subluxations, and can even progress to bony glenoid wear and affect core stability and the full kinetic chain. This interconnected cascade strongly supports the principle that early treatment and stabilization are highly advantageous. You want to stop that negative cycle. 2.1 shoulder injuries in overhead athletes. The kinetic chain challenge.
Okay, let's zoom in now on the unique, often extreme demands placed on the shoulders of overhead athletes. Think pitchers, tennis players, javelin throwers. How does their specialized high-velocity movement, governed by this intricate kinetic chain you mentioned, lead to very specific injury patterns that differ from, say, contact athletes?
The kinetic chain is indeed the cornerstone of overhead athletic performance. We define it as an orchestrated system of sequential body positions and motions, precisely designed to efficiently transfer the maximum force generated in large muscles of the core and lower leg all the way up to the hand. This provides distal arm mobility on a stable proximal base at the scapula. What's critical to understand is that even with a fully functional kinetic chain, the repetitive tremendous forces created on the glenohumeral joint during the throwing motion can still lead to microdamage of tendons and ligaments over time.
Just the sheer repetitive force.
Exactly. But crucially, shoulder symptoms in overhead athletes are predominantly related to a failure of this kinetic chain, specifically at the hip joint, the trunk, and the scapula. This failure fundamentally alters shoulder biomechanics, resulting in overstress on the glenohumeral structures themselves.
So the shoulder takes the hit for a problem elsewhere.
Very often, yes. Consider a compelling mathematical study that demonstrated that a mere 20% reduction in trunk kinetic energy development necessitates a compensatory 33% increase in velocity in the distal segments, the arm, to maintain the same energy at ball impact. This vividly highlights the profound impact of proximal dysfunction on the entire system. The shoulder ends up working overtime.
That's a really clear illustration. How do these athletes typically present?
Well, when it comes to diagnosis, we differentiate between two primary stages of presentation. The early stage is characterized by shoulder symptoms without anatomical failure. This often presents as inflammation, perhaps what's termed a disabled throwing shoulder or pathologic kinetic chain syndrome. Most symptoms at this stage can be effectively treated non-operatively. The advanced stage, however, involves anatomical failure that necessitates evaluation through advanced imaging studies like X-ray, CT, MRI, and ultrasound to confirm the diagnosis.
And what specific injuries are common in this group?
Within this population, we see very specific injuries and pathomechanisms. SLAP lesions, particularly type 2 superior labrum, anterior-posterior lesions, and associated biceps tendinitis are common findings. Rotator cuff injuries also present uniquely here. Articular-sided partial thickness tears of the supraspinatus and infraspinatus tendons in this population may not always be true rotator cuff tears in the traditional sense.
How so?
They might actually represent detachment of the superior shoulder capsule from the greater tuberosity, given its substantial attachment area. High-grade partial tears, or complete tears, present more typically with positive subacromial impingement test and decreased muscle strength. Cadaveric studies show that superior capsule tears specifically increase anterior and inferior translations.
Okay. What else?
Dysfunction of the anterior capsular ligament complex, whether through tearing or elongation, leads to anterior shoulder instability and can significantly disable the throwing shoulder. We also see little league shoulder or proximal humeral epiphysiolysis. That's a specific epiphyseal plate injury common in adolescent throwing athletes due to repetitive stress on the weaker growth plate. Beyond structural issues, neurovascular entrapment is a possibility, including suprascapular nerve entrapment, as well as vascular problems, such as effort thrombosis of the axillary artery or vein, or thoracic outlet syndrome, which are often quite difficult to diagnose.
Yeah, the impingement types.
Yes, shoulder internal impingement is a critical pathomechanism here. It's that abnormal contact between the undersurface of the rotator cuff and the posterior superior labrum and glenoid during the late cocking phase of throwing. While it can be physiological to some degree, forceful internal impingement becomes pathological and is thought to be a primary cause of posterior rotator cuff injury and type 2 SLAP lesions.
What increases that forceful contact?
Key factors include posterior capsule tightness, increased shoulder abduction and external rotation, decreased internal rotator muscle strength, and increased scapular internal rotation or dyskinesis. Subacromial impingement, the more classic type, is mostly diagnosed in older overhead athletes and is often associated with decreased upward scapular rotation and posterior-inferior capsule tightness. The peel-back mechanism is a specific pathomechanism described for type 2 SLAP lesions, where cadaveric studies have shown excessive humeral external rotation causes increased strain on and detachment of the superior labrum. And finally, Jobe and colleagues postulated that capsular laxity due to repetitive microtrauma in overhead athletes may result in increased shoulder laxity with secondary pathologies, defining this as pathologic shoulder laxity.
Given these complex and often subtle injuries, how do clinicians accurately diagnose them, especially when, as you said, imaging findings can sometimes be misleading? What are the absolutely crucial elements of the physical examination for an overhead athlete?
This is where precision in physical examination becomes absolutely critical, because as you noted, imaging alone can be insufficient or even misleading due to asymptomatic pathology often found in athletes. A thorough physical examination for overhead athletes must include a detailed scapular assessment. Tests like the scapula spine distance test and the elbow extension and elbow push tests help assess scapular stabilizers.
What about strength?
For muscle strength evaluation, we use manual muscle testing on that 0-5 scale, assessing shoulder abduction in the full can position, and external and internal rotation strength. An abnormal result is typically defined as muscle strength on the dominant side being less than that on the non-dominant side. To assess posterior tightness, we perform the combined abduction test and horizontal flexion test meticulously, with the examiner fixing the scapula to prevent compensatory movement. Capsule laxity is evaluated via load and shift testing in anterior, posterior, and inferior directions, along with the anterior apprehension and relocation tests. It's abnormal when the dominant side shows increased laxity or the subject feels instability.
And impingement tests.
For subacromial impingement, we perform the standard Neer, Hawkins, and Yoakum tests. Pain during any of these is considered abnormal. The hyperexternal rotation test has a specific role in evaluating the peelback mechanism and pathologic internal impingement. To systematically evaluate these findings, a comprehensive scoring sheet like the Hera test can be incredibly useful in practice.
Okay, so the physical exam is key, but what about imaging? You mentioned caveats.
Yes, regarding imaging, it's vital to reiterate why it can be misleading in throwing athletes.
Yeah.
While MRI or MR arthrograms are useful for detecting partial or complete rotator cuff tears and SLAP lesions, it's crucial to understand that significant amounts of shoulder pathology, especially partial thickness tears, found in maybe 86% of patients in some studies, can actually be present in asymptomatic athletes.
So a tear on MRI doesn't automatically mean it's the source of pain.
Exactly. Therefore, we must stress the critical importance of performing a thorough history and physical examination. Pain may not be directly correlated with imaging findings, and even things like SLAP tears often do not require immediate intervention, especially if they appear incidental. Clinical correlation is everything. 2.2 Scapular dyskinesis, the unstable platform.
You've highlighted scapular dyskinesis several times now as a critical factor in athletic shoulder injuries. Here's where it gets really interesting for me. How does this unstable platform of the scapula fundamentally disrupt shoulder function and contribute to this cascade of injuries? And most importantly for our audience, how can we accurately spot and assess it in clinical practice?
The scapula's role is truly indispensable. It's a pivotal link in the kinetic chain, as we discussed. Think of it as the central segment bridging the larger body segments, generating force to the legs and trunk, with the smaller arm segments producing precision and applying that force. Skillful athletic activities demand precise, coordinated motions of the scapula and the glenohumeral joint. Any alterations in these motions, either separately or coupled, can lead to inefficient shoulder function, decreased performance, and of course, increased injury risk.
So what exactly is scapular dyskinesis?
Well, it's defined quite simply as the loss of control of normal resting scapular position and dynamic motion. It has a surprisingly high prevalence, found in perhaps 100% of patients with shoulder injuries in some studies.
That high, really?
Yes, but it's crucial to clarify this. Dyskinesis is best considered a potential impairment of optimum shoulder function. If it's found alongside shoulder symptoms, it certainly warrants further evaluation to determine its contribution, but it's not automatically the sole cause.
Okay, so it's a finding that needs context. What pathologies is it associated with?
There are strong associations between scapular dyskinesis and various shoulder pathologies, each with fairly clear underlying mechanisms. For instance, there's a high association with labral injury. Altered scapular position and motion, things like increased internal rotation and anterior tilt, change the glenohumeral alignment. This places increased tensile strain on the anterior ligaments, increases that peel-back force on the biceps labral complex, and can create pathological internal impingement.
And GRRD makes this worse.
These effects are certainly magnified in the presence of glenohumeral internal rotation deficit, or GRR. The fact that manually retracting the scapula can often correct symptoms found in tests like the modified dynamic labral shear test really highlights the role of dyskinesis.
What about impingement?
Impingement, both internal and external, is frequently seen in throwing athletes, often secondary to other pathology. Scapular dyskinesis contributes by altering the resting and dynamic scapular position, typically a loss of acromial upward rotation, excessive scapular internal rotation, and excessive scapular anterior tilt. These positions essentially create scapular protraction, which narrows the subacromial space and has been shown to decrease rotator cuff strength. Altered muscle activation patterns like increased upper trapezius activity and delayed or decreased lower trapezius and serratus anterior firing are also implicated.
And AC joint injuries, how does dyskinesis link there?
AC joint injuries remove the strut function of the clavicle. This allows what's called the third translation of the scapula, meaning it moves inferiorly and medially relative to the clavicle. This changes the biomechanical axis of scapulohumeral rhythm, leading to excessive scapular internal rotation and protraction and decreased dynamic acromial elevation. This protracted scapular position is directly linked to many dysfunctional problems seen in chronic AC separations, including impingement and reduced cuff strength.
So it disrupts the whole shoulder girdle mechanism.
Precisely. Clavicle fractures can also lead to dyskinesis if the clavicle anatomy isn't perfectly restored. Shortened malunions, or non-unions, alter scapular position towards internal rotation and anterior tilt. In these cases, dyskinesis can actually serve as a crucial clinical sign of potentially harmful alteration of clavicle anatomy, helping inform the decision for operative treatment. And finally, though rare, scapular muscle detachment, typically the lower trapezius and rhomboids, is an often missed injury that directly causes dyskinesis, usually presenting with scapular protraction and lateral translation.
Given these complex implications, how do clinicians accurately evaluate the presence and impact of scapular dyskinesis on, say, the throwing athlete? What specific tests should we be incorporating into our routine examinations?
Evaluating the scapula requires a comprehensive approach. We must begin with a thorough history, asking about past trauma to the scapula, clavicle, or AC joint, any spinal symptoms, and previous rehab efforts. The goals of the examination are, first, to establish the presence or absence of dyskinesis. Second, to determine the effect of corrective maneuvers on the patient's symptoms. And third, to investigate potential underlying causes like bony issues, joint derangement, or muscle imbalances.
How do you observe it?
The scapular exam should ideally be performed from the posterior aspect with the scapula fully exposed. We visually assess resting posture for any side-to-side asymmetry or prominence of the inferior medial or medial border. The optimum position for evaluating dynamic scapular dyskinesis is during active forward flexion, watching the scapula move.
And the corrective tests?
Crucially, we use corrective maneuvers like the scapular assistance test, or SAT, where the examiner assists upward rotation, and the scapular retraction test, or SRT, where the examiner manually retracts the scapula. A positive SAT or SRT, meaning the patient's symptoms improve with the correction, strongly indicates that scapular dyskinesis is directly involved in producing those symptoms and highlights the immediate need for early scapular rehabilitation.
What else should be checked?
We also perform coracoid-based inflexibility assessment through palpation of the pectoralis minor and short head of the biceps, noting tenderness in taut bands. Proximal kinetic chain screening, using tests like the one-leg stability series, is useful to assess core and lower extremity contributions. And of course, a thorough glenohumeral exam is crucial for evaluating internal derangement and AC joint instability, paying special attention to assessing GRD and labral injuries, as both are frequently associated with dyskinesis. Remember, for accurate GRD measurements, the patient must be supine, with a second examiner stabilizing the scapula.
So, if the scapula is such a critical player, how do we get it back in the game effectively? What does this mean for rehabilitation to ensure not just recovery, but optimal athletic performance?
Well, it means rehabilitation must absolutely start with optimizing the anatomy first. You can't effectively rehabilitate around a significant structural problem. Local issues like nerve injury or scapular stabilizer muscle detachment require repair or muscle transfer. Similarly, bony and tissue derangement issues, AC joint or clavicle injury, labral injury, rotator cuff disease, glenohumeral instability must be surgically addressed before effective rehabilitation can truly proceed.
Get the foundation right first.
Exactly. Once that foundation is set, we follow a comprehensive protocol, often based on established approaches like those from Ellenbecker and Cools. We typically begin with kinetic chain exercises, focusing on the trunk and hips, starting from and ending at the ideal position of hip and trunk extension. These can often be initiated preoperatively. For flexibility, we address specific areas of tightness, particularly the anterior coracoid, the pectoralis minor, and short head of biceps and shoulder rotation. Exercises like the open book and corner stretch for the coracoid muscles and the sleeper and crossbody stretch for shoulder rotation are common recommendations.
And the strengthening part.
Periscapular strengthening is paramount. We emphasize achieving a position of scapular retraction, as this is the most effective position to maximize the scapula's stabilizing roles. Exercises like the scapular pinch or trunk extension with scapular retraction can be done standing to simulate normal activation sequences. Once scapular control is achieved, we integrate scapular rotator cuff exercises, such as punches and shoulder dumps. These stimulate rotator cuff activation off a stabilized scapula and are performed in various planes using different resistance types. We particularly exploit the transverse plane for many activities.
And progressing towards sport.
Finally, when strength and stabilization are achieved through controlled, supervised rehabilitation, we implement a three-area focus for effective transition back to sport. This involves 1. Lower extremity muscle power and endurance. 2. Integrated sport-specific exercise to improve proprioception and muscle education. And 3. Upper extremity power and endurance using high-repetition, long-lever exercises. This holistic progressive approach is absolutely vital for the athlete's full recovery and return to optimal performance.
Okay, let's switch gears now. Moving from the precision-demanding overhead sports to the sheer force and collision inherent in sports like rugby, American football, and ice hockey. How do these high-energy impacts fundamentally change the injury landscape for the shoulder? What's particularly unique about their mechanisms and the apparently high frequency of concomitant injuries?
It's a completely different dynamic, absolutely, driven by direct force and high-energy impacts. First, it might be useful to make a key distinction. Collision sports involve athletes purposely hitting or colliding with each other or inanimate objects, often with great force, think rugby, American football, ice hockey. Contact sports, technically, involve routine contact, but with lesser force, maybe like basketball or football, soccer. While collision implies greater risk, the terms are often used pretty synonymously in the literature.
Right, but the forces involved are generally higher in collision sports.
Definitely. And because of the physical nature of these sports, musculoskeletal injuries are incredibly frequent. The shoulder consistently ranks among the most common injury sites. Glenohumeral instability and rotator cuff injuries are particularly prevalent. Crucially, shoulder dislocation and instability account for the majority of playtime loss. Hetty and colleagues, for instance, reported a mean of 81 days absent from play for shoulder dislocation in professional rugby union. That's a significant chunk of a season.
81 days, wow. And the mechanisms, different from throwing.
Yes, quite different. Shoulder injuries here can result from a direct blow to the shoulder itself, or indirectly from landing heavily on the affected shoulder. What's striking is that the tackling event alone is responsible for a staggering 65% of all shoulder injuries in rugby.
The tackle itself.
Yes. Video analysis studies, like one by Crichton and colleagues in elite rugby players, have identified three common mechanisms during tackles. The try-scorer, hyperflexion of the outstretched ball-carrying arm, the tackler, extension of the abducted arm behind the player during a tackle, and direct impact, a direct blow to the side of the shoulder. Posterior glenohumeral instability can also result from a blocking injury, as seen perhaps with an American football lineman blocking with the arm flexed and internally rotated.
And you mentioned concomitant injuries are common.
Yes, this brings us to a really unique aspect, the high incidence of concomitant injuries. Complex injuries involving multiple structures often occur after just a single traumatic event in these sports. Tischer and colleagues found that a significant 18.2%, almost 1 in 5, of AC joint injuries exhibited concomitant intra-articular injuries that actually necessitated additional surgical intervention. This underscores the importance of appreciating that when a contact athlete presents with a shoulder injury, there's a strong likelihood of multiple coexisting pathologies that need addressing. You can't just focus on the most obvious injury. 3.2 rotator cuff injuries in contact athletes.
Rotator cuff injuries are prevalent across all sports, as you said, but how do they specifically manifest and, more importantly, how are they managed differently in a contact athlete, where direct impact is a constant threat compared to, say, an overhead thrower where it's more overuse?
The manifestation and management in contact athletes indeed have distinct characteristics. In this population, rotator cuff injuries range from simple contusions right through to full-thickness tears. It's noteworthy that contusions alone accounted for nearly half, 47%, of all shoulder injuries in one study of a North American professional football team. So simple bruising is very common.
And the tears themselves, usually traumatic.
Yes. For full-thickness tears, the predominant mechanism of injury is traumatic, and they are typically associated with shoulder dislocations or subluxations. This differs from the microtrauma and overuse patterns often seen in overhead athletes. Tambay and colleagues reported that approximately half of professional rugby players with full-thickness rotator cuff tears also had concomitant labral injuries or bony Bankart lesions, again highlighting that multi-injury pattern common in contact sports.
So how do you manage them? Is surgery always needed for a tear?
Not necessarily. When it comes to management strategy, cuff contusions and partial tears can often be managed non-operatively. This typically includes pain control, a structured rotator cuff strengthening program, and perhaps consideration of subacromial corticosteroid injections for athletes with persistent bursal inflammation and pain. Surgical management is generally indicated for patients who don't respond to these conservative treatments, and certainly for those with full-thickness cuff tears, especially in younger, active individuals. The advancements in arthroscopic techniques have been transformative here. They enable successful treatment of cuff tears in contact athletes with minimal soft tissue damage, allowing for a confident repair of the rotator cuff, and, importantly, any associated pathology found at the same time.
And the outcomes? Can they get back to playing rough sports?
The outcomes are actually very encouraging. In that series by Tamby and colleagues I mentioned, an excellent 91.7%, that's 10 out of 11 of the elite rugby players, were able to return to their pre-injury level of competition relatively early, on average around 4.8 months after arthroscopic rotator cuff repair.
That's impressive.
It demonstrates that with the right surgical approach and rehabilitation, even significant injuries in these high-demand athletes can be effectively managed, allowing a return to collision sports. 3.3 glenohumeral joint instability, a common challenge.
Glenohumeral joint instability. This sounds like a really common and often disabling injury for the contact athlete, with implications that could potentially sideline careers. What are the key considerations when making treatment plans for these high-stakes athletes, particularly regarding surgical timing and the specific techniques used?
This is perhaps one of the most critical and complex decisions we face when treating contact athletes. While anterior instability comprises the majority of shoulder instability cases overall, recent studies indicate that posterior instability is actually increasing in this group and can account for as much as 10–30% of traumatic instability in contact athletes.
So posterior instability is more common than we might think in this group.
It appears so. And interestingly, posterior instability is also often associated with anterior instability and superior labral tears in these athletes, adding to the complexity.
So the big question: operate early or try non-operative first, especially if it happens mid-season?
Exactly. The choice between early surgery or non-operative treatment must be highly tailored to the individual athlete, especially for mid-season injuries. It's a decision that involves carefully weighing numerous factors. We have to consider the type of sport, the level of competition, the athlete's playing position and age, the specific pathanatomy. Things like significant glenoid bone loss or an engaging Hill-Sachs lesion are major factors. Then there's the timing of the injury within the competitive season, the athlete's own career goals, and even the expectations from coaching staff or family members. It's a multifaceted discussion.
And surgery usually means the season's over?
Yes, it's important to acknowledge that surgical stabilization typically sidelines athletes for 4–6 months, which is usually season ending. This poses a significant dilemma for an in-season player and their team.
So what does non-operative management look like if they want to finish the season?
For non-operative in-season management, we can use accelerated rehabilitation protocols. These are designed for athletes strongly motivated to play through the season, reserving surgery for the off-season. These protocols minimize immobilization, perhaps none, or up to 7 days max, and initiate supervised rehabilitation from day one as tolerated. This starts with gentle range of motion exercises and cryotherapy, followed by rotator cuff and periscapular muscle strengthening once full ROM is achieved without discomfort. Sport-specific drills follow later.
Can they play with a brace?
Return to play with a motion-limiting brace was considered when specific, comprehensive criteria are met. Little or no pain, the athlete's subjective feeling of stability, near normal ROM, strength, and functional ability.
But does it work? What are the recurrence rates?
That's the major downside. Studies highlight significant recurrence rates with this approach. Buss and colleagues reported that while most athletes manage non-operatively return to play, 41% experience recurrence. Bottoni and colleagues reported an even higher recurrence rate of 75% in their cohort treated non-operatively.
75%, that's very high.
It underscores the challenges of managing significant instability non-operatively in contact athletes trying to continue playing.
So when is surgery definitely the better option?
Well, surgical treatment is indicated for failure of non-operative treatment, obviously, or, importantly, the presence of high-risk factors from the outset, such as significant glenoid bone loss or an engaging Hill-Sachs lesion. These warrant early surgical intervention to prevent further damage and recurrence.
And the type of surgery, has that changed?
Yes, it has evolved. Historically, open Bankart repair with a capsular shift was considered the gold standard for contact athletes due to its perceived robustness. However, with the development of new implants and significant advancements in arthroscopic surgical techniques, arthroscopic stabilization has gained enormous popularity and now offers comparable outcomes in many cases, with potentially less morbidity.
But arthroscopy isn't always successful.
No, and it's crucial to understand the risk factors for surgical failure, particularly with arthroscopy. Burkhardt and De Beer famously reported a much higher recurrence rate after arthroscopic Bankart repair for patients with significant glenoid bone loss and engaging Hill-Sachs lesions. These critical bone defects compromise the procedure.
Which brings us back to the glenoid tract concept.
Exactly. Yamamoto and colleagues' glenoid tract concept is now invaluable for guiding clinical decision-making in these cases. Remember, it defines the contact zone between the humerus and glenoid. If a Hill-Sachs lesion remains within the glenoid tract, on track, there is no risk of engagement. However, if it extends medially over the glenoid tract, off track, there is a high risk of engagement during functional movement, making simple soft tissue repair likely to fail.
So what you do for those off-track or large bony defects?
To address large humeral head defects, off-track Hill-Sachs, surgical options include humeral head osteochondral allograft or the infraspinatus rumpelisage procedure, where the infraspinatus tendon is sewn into the defect to prevent engagement. For significant glenoid bone loss, the Latarjet procedure is often considered. This involves transferring the coracoid process with its attached tendons to the front of the glenoid.
How does Lidojet work?
It provides stability through three key effects: a bone graft effect, restoring the glenoid surface, a sling effect from the conjoint tendon acting like a hammock, and a capsular repair effect. It's important to acknowledge, though, that these are non-anatomic procedures and are associated with reported complication rates ranging from 5% to 30%, so patient selection and technical execution are key. Comprehensive algorithms exist now to help guide the management decisions based on these factors. 4.1 Acromioclavicular joint injuries, a persistent problem.
Okay, let's move slightly away from the main ball and socket joint. Often overshadowed by the glenohumeral joint, the AC joint plays a subtle yet absolutely critical role in shoulder function, especially in those kinetic chain movements we talked about. Its injuries, however, seem notoriously tricky to classify and manage, particularly in contact athletes. What's crucial for us to understand about AC joint anatomy, its common injury patterns, and how do we accurately diagnose and approach treatment for these persistent problems?
You've hit on a crucial point about the AC joint's often underestimated importance. It's a robust synovial articulation connecting the clavicle to the scapula, featuring an intra-articular fibrocartilaginous disc, though that disc rapidly degenerates beyond the fourth decade, typically. Its primary stabilizers are the dynamic muscles crossing the joint, the deltoid and trapezius, and the static ligaments. The acromioclavicular, AC ligaments, providing anterior-posterior stability, and the coracocalycular, CC ligaments, the conoid and trapezoid, providing vertical stability.
And both sets of ligaments are important.
Critically important. It's vital to understand that these injuries rarely occur in isolation, highlighting the importance of anatomic reconstruction of both the AC and CC ligaments for maximum healing strength if surgery is undertaken. Codman famously observed that the AC joint moves very little, but in many planes, and crucially, an intact ACJ is essential for scapular motion to be synchronously coupled with arm motion.
Ah, so it links the clavicle and scapular movements.
Precisely. If the ACJ is fixed, say with screws or plates, motion will be lost, limiting shoulder function, or the hardware will eventually fail due to this obligatory coupling of clavicle rotation with scapular motion. This is clinically significant, as long-standing type 3 AC joint injuries, complete tears of both ligaments, lead to scapular dyskinesis in 71% of patients, often presenting as the so-called SICK scapular syndrome.
So how do these injuries usually happen?
Etiologically, AC joint injuries typically result from a direct blow to the point of the shoulder, the lateral acromion, or indirectly from landing hard on the affected shoulder, driving the acromion and scapula inferiorly and anteriorly. This causes the clavicle to be relatively displaced superiorly, leading to sequential tearing of the AC and then the CC ligaments.
In classification, you mentioned it's tricky.
Yes, classification of AC joint injuries, using the widely used Rockwood classification, types ISI based on displacement, is challenging because relying solely on radiographs has proven unreliable for determining the true pathological classification and guiding treatment. This led to the Isocos Upper Limb Committee's 2014 consensus document, which diversified the contentious type 3 injuries, the ones where both AC and CC ligaments are torn, but displacement varies into type I, functionally stable, and type I, functionally unstable.
Based on clinical factors, not just x-rays.
Exactly. This distinction is based on clinical factors assessed 3 to 6 weeks post-injury, including things like ongoing pain, especially over the anterior acromion, rotator cuff or medial scapular area, weakness during rotator cuff testing, decreased flexion and abduction ROM, and demonstrable scapular dyskinesis on observation.
How do they look clinically?
In clinical examination, complete AC joint disruptions, Rockwood grades the third, present with that classical obvious deformity or step-off. These may be locked, meaning not easily reducible and limiting scapular excursion, or shocked, unstable but easily reducible. For less obvious disruptions, grade 3-2, cross-arm adduction often accentuates the injury, displacing the clavicle superiorly and posteriorly. The diagnostic triad of ACJ injury includes point tenderness directly over the joint, ACJ pain with cross-arm adduction, and importantly, pain relief by local anesthetic injection into the joint. The Paxinos test can also be helpful.
What about X-rays? Is there a specific view?
For radiographic evaluation, the Zonka view, a 15-degree cephalid tilt view, is considered the most accurate for visualizing the AC joint itself, though its inter-eye and intra-observer reliability is acknowledged to be poor. Standard shoulder views often don't show it well. While CT scans are best for appreciating static bony displacement, clinical assessment can be equally reliable. MRI can be useful for assessing soft tissue damage, particularly the ligaments in acute scenarios.
Management of AC joint injuries often sparks significant debate, doesn't it? Particularly regarding when to opt for non-operative versus operative approaches, especially considering the high functional demands and career implications for athletes. What's the current thinking and what principles guide that decision-making process?
The management philosophy for AC joint injuries has definitely been shifting. Recent evidence increasingly supports initial primary non-operative treatment for even complete AC joint dislocations, type 3 and some higher grades. Reviews report successful outcomes in around 88% of patients treated non-operatively, comparable to operative groups in many studies. This really underscores that the grade of AC joint injury alone should not be the primary determinant for defining treatment options, due to that poor correlation with clinical symptoms we discussed. Patient function and symptoms are more important.
So what does non-operative treatment involve?
For non-operative treatment, particularly acute injuries less than a week old, initial management involves simple analgesia, topical ice therapy, and rest in a sling, primarily for comfort. A supportive broad-arm sling is generally preferred over a collar and cuff. The sling should typically be discarded once symptoms settle, usually within 1 week. Rehabilitation then follows a structured protocol, like Gladstone and colleagues' 4-phase protocol. This progresses from Phase 1, pain control, immediate protective ROM isometrics, to Phase 2, isotonic strengthening. Phase 3, unrestricted functional participation, neuromuscular control, and finally Phase 4, return to activity with sport-specific drills.
When can they return to contact sports?
Contact sports and heavy lifting can usually be started as comfortable, typically around 6-12 weeks post-injury. However, it's important to counsel patients that local discomfort may persist with activity for up to 6 months. And those concerning statistics from Cox show that a large proportion of athletes remain symptomatic at 6 months, particularly with grade 3 injuries, and 30% of overhead athletes were unable to continue at the same level of sport after non-operative treatment.
So non-operative isn't always the final answer for high-demand individuals. When is surgery indicated?
Surgical treatment is typically reserved for patients with high functional demands who remain symptomatic, those with a clinically symptomatic locked or unstable shocked scapula, and patients who simply fail to improve after an initial 3 to 6 weeks of appropriate non-operative symptomatic management. The aim of surgery is to achieve a painless, stable shoulder with adequate mobility, strength, and muscle control, allowing the individual to return to their desired level of activity.
And the surgical techniques. You mentioned over 100 historically.
Yes. Historically, the proliferation of over 100 different surgical techniques indicated a lack of consensus on the optimal treatment. Techniques like the Weaver-Dunn procedure, which involved transferring the coracoacromial ligament, only reproduced about 25% of the native CC ligament strength and had high failure rates. Hook plates provided stable reduction but could cause rotator cuff impingement and required secondary removal, often performing worse than CC ligament fixation.
So what's the trend now?
Current surgical trends are moving firmly towards anatomical restoration of both the CC and AC ligaments, often with some form of biological enhancement, using strong constructs that allow for early mobilization and reduce the risk of redisplacement. Coracoclavicular fixation has evolved from the original Bosworth screw to modern suture button constructs, like the dog bone or tightrope systems, now using multiple buttons and strong tape sutures for increased strength and arthroscopic amenability. Free graft augmentation or reconstruction, using tendon grafts like gracilis or semitendinosus placed in an anatomic position to reconstruct the trapezoid and conoid ligaments, has shown ultimate failure loads equivalent to native intact CC ligaments, although graft fixation itself remains a technical challenge. Loop reconstruction techniques, using synthetic ligaments like Lars or Surgilig, are purported to allow early postoperative functional treatment and potentially earlier recovery, with improved implant technology minimizing older issues like clavicular osteolysis. Repair and reinforcement of the superior AC ligament is also often combined with these techniques to improve horizontal stability.
And your preferred technique?
Our preferred technique involves the use of a strong synthetic polyethylene netta triphelate ligament, specifically the Liers ligament. We use an anatomical construct passing it through drill holes in the clavicle and around the coracoid, combined with a reefing repair of the ACJ capsule and the overlying delta trapezial fascia. This Liers ligament actually exceeds the tensile strength of native CC ligaments and encourages fibroblast and collagen ingrowth. We've also modified this by adding a further figure-of-8 loop around the coracoid and or over the ACJ via a drill hole in the acromion to further improve horizontal stability and overall construct strength. Our own results with this have been positive, showing a low 2% loss of reduction.
And rehabilitation after surgery, is it milestone-based?
Absolutely. Post-operative rehabilitation is crucial, and progression through the phases is not time-based, but strictly milestone-based, depending entirely on the patient's responses and ability to progress safely. Phase 1 involves protective, gentle pendulum exercises and passive range of motion. Phase 2 progresses to light resistance and sport-specific rehabilitation, including plyometrics and perturbation training. Phase 3 focuses intensely on regaining scapula and glenohumeral stability and control.
And return to sport.
Sport-specific rehabilitation commences within weeks. Return to sport participation and competition is graduated, always requiring input from the surgeon, the therapist, and the strength and conditioning coaches. Typically, this is achieved within 3 to 4 months for contact athletes and perhaps 6 to 9 months for overhead athletes, though some, like horse riders and cyclists, often return in less than 3 months. 4.2 sternoclavicular joint injuries, the body's most stable joint.
Right. If the AC joint can be subtly tricky, the sternoclavicular, or SC joint, presents a different challenge altogether. It's often described as inherently the most stable joint in the body, yet its injuries can be incredibly deceptive, even potentially life-threatening. What makes the SC joint so incredibly stable? What are the subtle diagnostic clues we should never miss? And how do their distinct characteristics dictate management, especially the really urgent ones?
The SE joint is truly an anomaly in its stability. Despite having largely incongruent articular surfaces and a small contact area, it is extremely stable due to very robust static and dynamic stabilizers. Its static stabilizers include the inherent, albeit limited, congruity of the articular surfaces, the extremely strong anterior and posterior sternoclavicular ligaments, these are the most important for anterococcolectular stability, the intra-articular fibrocartilaginous disc, which divides the joint and acts a bit like a knee meniscus, and the interclavicular and costoclavicular ligaments. Dynamic stabilizers include the surrounding musculotendinous envelope, particularly the sternocleidomastoid, subclavius, and pectoralis major muscles.
And there's a key point about younger patients.
Yes, this is a crucial developmental point for clinicians.
Mm-hmm.
The epiphysis, or growth plate, of the medial end of the clavicle is the last epiphysis in the body to close, usually between 25 and 31 years old. This is critically relevant because significant traumatic injuries in patients younger than 25 are far more likely to result in a displaced medial physeal fracture, a growth plate injury, rather than a true SC joint dislocation, simply because the physis is inherently weaker than the incredibly strong SC joint ligaments before it fuses.
So always consider a physeal fracture in younger patients with apparent SCJ disruption.
Absolutely. The SC joint itself moves in 3 planes: retraction, protraction, elevation, depression, and rotation coordinating with AC joint movement to optimally position the glenoid.
How do we diagnose these injuries? What should we look for?
When unraveling SCJ injuries, a detailed history is vital. Acute injuries typically involve a high-energy mechanism, like a direct blow or fall. Chronic problems may follow previous trauma or activity changes. In younger patients, atraumatic instability can present with pain, clicking, or recurrent dislocation without a specific injury. And it's worth asking about connective tissue disorders, like Ehlers-Danlos or Marfan's. On inspection, we look for deformity or muscle wasting compared to the other side. Palpation involves checking the SEC joint for swelling, differentiating between soft tissue swelling like effusion or synovitis, and hard swelling from a chronic dislocation or osteophytes, and assessing tenderness. We assess movements of the SE joint in all 3 planes: protraction, retraction, arms forward; elevation, depression, arms abducted; and rotation, arms abducted, elbows flexed. We palpate the anterior joint during movement for abnormal motion or clicking, which might suggest degenerative changes or disc tears. In cases of instability, the medial clavicle may sublux or dislocate anteriorly.
And imaging. CT seems key here.
Yes, for imaging, while X-rays, AP, lateral, can be helpful, a CT scan is undoubtedly the investigation of choice. It accurately assesses the position of the medial clavicle relative to the sternum and crucially differentiates a true dislocation from a physeal fracture. And most importantly, for posterior dislocations where there's any concern for mediastinal compromise, a CT angiogram should be undertaken as a matter of urgency to visualize the great vessels, like the aorta and subclavian vessels, and the tracheoesophagus in relation to the displaced medial clavicle.
So CT angio for suspected posterior dislocations. What about MRI?
MRI offers poorer bony resolution compared to CT, but can effectively demonstrate ligamentous structures, intra-articular disc injuries, and the adjacent neurovascular anatomy if needed.
Okay, what are the most concerning types of SC joint injuries, particularly those posterior dislocations you mentioned? How do their distinct, often life-threatening characteristics dictate management, including the need for urgent intervention and specialized surgical considerations?
SC joint instability can be classified by direction, anterior, posterior, severity, sprain, subluxation, dislocation, or chronicity, acute, recurrent, persistent. But the Stanmore triangle classification is also useful as it considers the cause. Type I, traumatic, type 2, atraumatic structural laxity, and type 3, non-structural muscle patterning.
Let's focus on type 1, the traumatic ones.
Type A traumatic structural instability involves those high-energy, high-stakes injuries. Traumatic SE joint dislocations are rare, less than 1% of upper limb injuries, usually resulting from significant force. The force is often indirect, transferred along the clavicle from a blow to the shoulder. A protracted scapula at impact increases the likelihood of posterior dislocation. A retracted scapula, anterior dislocation. Less frequently, a direct anterior blow to the clavicle can drive the medial end posteriorly into the mediastinum.
And posterior dislocation is the dangerous one.
Acute posterior dislocations are a particular concern. Yes, due to their potential to cause mediastinal compromise, making them a potential medical emergency. Clinicians must be extremely vigilant for features such as dysphagia, difficulty swallowing, dyspnoea, shortness of breath, stridor, hoarseness, or vascular symptoms like venous congestion or edema of the ipsilateral arm. These suggest pressure on the great vessels or the tracheoesophagus. While these complications are rare, they can be devastating, and their probability increases the longer the dislocation remains unreduced.
How are they managed based on direction and timing?
Management strategies depend critically on the direction and timing. Undisplaced ligamentous sprains, grade 1, and subluxations, grade 2, as well as minimally displaced medial physeal fractures, are typically treated conservatively with reassurance, analgesia, ice, and a short period of immobilization in a sling for comfort. Patients are advised to avoid re-injury for about 3 months.
What about acute anterior dislocations?
For acute anterior dislocations, usually within 48 hours, a closed reduction under sedation or general anesthetic can be attempted by applying posterior pressure. However, the SC joint often redislocates immediately or soon after, with recurrence rates over 50%. Because of this high recurrence rate and the fact that anterior dislocations rarely cause long-term functional issues, most surgeons adopt a wait-and-see policy. Symptoms typically settle with conservative management over 3 to 6 months. Surgery is considered only in unusual situations with significant persistent symptoms despite adequate non-operative management, and after muscle patterning issues have been excluded.
And acute posterior dislocations, urgent reduction.
Yes, for acute posterior dislocations, again, ideally within 48 hours, there is a much greater imperative to reduce and maintain reduction due to that risk of mediastinal compromise. Closed reduction is undertaken under general anesthetic, often with fluoroscopy guidance, and involves specific maneuvers like placing a bolster between the scapulae, applying traction and extension to the abducted arm, and sometimes using a towel clip to grip and pull the medial clavicle anteriorly. Success rates for closed reduction are challenging, perhaps around 56% within 48 hours, dropping significantly after that. Crucially, the on-site cardiothoracic surgeon should always be informed prior to booking for closed reduction due to the potential need for immediate open reduction if closed reduction fails or vascular complications arise during the attempt.
What happens after successful reduction?
Post-reduction, a figure-of-8 brace is often used for about 4 weeks to maintain scapular retraction and reduce stress on the joint, and contact sports are avoided for 3–6 months.
When is open surgery needed?
Open reduction and reconstruction are indicated for failed closed reductions, delayed presentations, more than a few days, or chronic posterior dislocations that cause significant functional deficit or carry a high risk of erosion into vital structures. Since the normal capsular and ligamentous stabilizers are usually damaged and only partially repairable, additional reconstruction is typically required to maintain the reduction. Historically, wires and pins were used, but were abandoned due to lethal complications like intrathoracic migration. Current trends favor reconstruction using autograft, like palmaris longus or semitendinosus tendon, or allograft. A figure-of-8 reconstruction technique, where the graft is shuttled through drill holes in the sternum and clavicle, tensioned and sutured, is considered biomechanically superior. Synthetic ultra-strong braided sutures can also be used to augment the graft.
And those medial physial fractures in under 25s.
Reiterate that these are fractures, not true dislocations. CT confirms the diagnosis. Most are or minimally displaced and managed non-operatively with immobilization. Open reduction is reserved only for those rare cases with mediastinal compressive symptoms.
Briefly, what about the other types of instability?
Type 2 intraumatic structural instability, or hypermobility, is due to capsular laxity, often bilateral, and frequently seen with generalized ligamentous laxity syndromes. Patients present with pain, clicking, and medial clavicle subluxation prominence, usually less painful than traumatic instability. This is managed non-operatively initially, with physiotherapy focusing on muscle patterning. Surgery might be considered for failed rehab. SCJ disc pathologies can cause pain and clicking, potentially treated with arthroscopic resection. SCJ osteoarthritis is common, especially in middle-aged women, managed conservatively first. NSAIDs, ICE, activity modification steroid injections. If that fails, surgical options include resection of the medial end of the clavicle, increasingly done arthroscopically. And finally, type 3 muscle patterning instability involves poorly coordinated neuromuscular control causing instability. This must be addressed with physiotherapy and biofeedback before considering any stabilization surgery. Botulinum toxin might even be used preoperatively to temporarily weaken offending muscles and protect a surgical repair. 5.1 clavicle fractures, more than just a broken collarbone.
Okay, let's move on to clavicle fractures. They're incredibly common, aren't they? Accounting for a significant portion of upper limb injuries. Yet, the approach to managing them seems to have evolved dramatically from the historical conservative norms. What's the latest evidence on when to manage these conservatively versus surgically, and why does this distinction matter so much for athletes, especially when considering complications like non-union and malunion?
Yes, clavicle fractures are very common. And the clavicle itself, that saw-shaped bone, is the only skeletal attachment of the scapula to the torso. This means a clavicle injury profoundly affects the entire shoulder biomechanics, disrupting that strut function. It's the first bone to ossify in the fetus, but its sternal end is the last epiphysis to fuse, as we discussed, around the 25th year. Clavicle fractures make up perhaps up to 5% of all fractures in the adult population, and the vast majority, 70–80%, occur in the midshaft, which is the thinnest and most exposed segment.
Who gets them most often?
Incidence is highest in males under 20, often due to sports injuries, which account for about 45% of cases in recent studies. Also, in polytrauma patients, early fixation of high-energy clavicle fractures is increasingly recognized for reducing ITU length of stay and facilitating mobilization.
How do they typically present?
Diagnosis is usually straightforward clinically. The typical mechanism is a fall under the shoulder or a direct blow, resulting in a compressive axial force. If displaced, the fracture can shorten due to unopposed muscle action. The sternocleidomastoid muscle pulls the medial fragment superiorly and posteriorly, while pectoralis, major and deltoid, pull the lateral fragment inferiorly and medially, leading to that characteristic ptotic or draught shoulder deformity and shortening. Careful assessment of the overlying skin for tenting by sharp fragments is crucial. Clinical measurement of clavicle length difference compared to the uninjured side and a thorough neurological examination are essential.
Can we predict who might have problems healing?
We can use a prognostic index to predict non-union risk. Factors like older age, female sex, shortening of greater than 2 centimeters, complete fracture displacement, being a smoker, and significant comminution are all negative predictive factors for union. So, for example, a 60-year-old woman with a displaced, comminuted midshaft fracture has an approximate 75% projected probability of non-union at 12 weeks if treated non-operatively. This clearly informs the management discussion.
Right. So how has management changed, especially for displaced fractures?
Well, undisplaced midshaft fractures, Robinson type 2A, are traditionally and still currently treated conservatively, usually with a broad arm sling, and they generally unite with excellent function. However, the management of displaced midshaft fractures has been the focus of the shift. Historically, these were also treated conservatively, based on the belief that most heal well functionally, even if they unite in a shortened position. But this has been strongly challenged by more recent high-quality studies indicating significantly higher non-union rates than previously thought, and potentially poorer functional outcomes, especially in younger active individuals.
What about non-operative treatment itself? Sling or figure of 8?
The broad arm sling is the most frequently used non-operative treatment now. It offers better patient satisfaction scores than the figure of 8 bandage, which was also shown in some studies to have a higher non-union rate, possibly due to distracting forces. Crucially, though, neither sling type can reliably reduce or hold the reduction of a displaced, shortened fracture. This means that conservative treatment for a significantly displaced fracture always results in some degree of malunion or healing in a shortened position. The sling is really just used for comfort until pain settles.
So the push is towards surgery for displaced ones.
Yes, the paradigm shift has been towards considering primary operative treatment for displaced midshaft fractures, particularly in active patients. Evidence from large trials, like those from the Canadian Orthopedic Trauma Association and UK trials, demonstrated that open reduction and internal fixation significantly reduced non-union rates down to around 2% versus 15% non-operatively, and were associated with better functional outcome scores and faster return to function.
But is the function better if they do unite non-operatively?
That's a key point. The improved outcome scores in the surgical groups primarily resulted from preventing non-union and malunion. There was actually little functional difference reported between surgically and conservatively managed fractures that did go on to unite, although union occurred faster with surgery. We must also acknowledge the higher complication rates, infection, hardware issues, need for removal, and greater expense associated with surgical intervention. So the treatment choice really needs to be individualized, carefully weighing the benefits of preventing non-malunion against the risks of surgery, considering the patient's activity level and expectations.
When surgery is indicated for clavicle fractures, what are the preferred techniques? What are their advantages and disadvantages? And what specific complications do clinicians need to be aware of?
When surgery is indicated, plate fixation via open reduction and internal fixation, or IF, is the most common surgical intervention worldwide. Doing the technique, meticulous care is taken to identify and preserve the supraclavicular nerve branches overlying the clavicle. Modern anatomically contoured locking plates allow for precise anatomical restoration and are designed to be less prominent than older plates. Plates are typically placed on the superior surface, which is biomechanically advantageous and generally requires minimal soft tissue detachment if done carefully. Interfragmentary lag screw techniques can be used prior to plating to provide compression and stabilize oblique or butterfly fragments. Anterior plating is another option some surgeons prefer, arguing it reduces plate prominence.
What are the downsides of plating?
Complications include infection, though typically low, around 1 to 5%, hardware prominence causing irritation, quite common, hardware failure, less common with modern plates, and the potential need for plate removal later on, which means a second operation. Reoperation rates are inherently higher with surgical treatment compared to non-operative treatment simply because of the possibility of hardware removal.
What about rods or nails inside the bone?
Intramedullary IM fixation is another technique. Its theoretical advantages include less soft tissue stripping, relative protection of the supraclavicular nerves, smaller incisions, and potentially shorter operating times. Historically, rigid pins or nails were used, but were largely abandoned due to serious complications, including intrathoracic migration. Modern techniques use elastic titanium nails, like 10 nails, which provide a 3-point fixation within the bone medulla and allow the fracture to heal primarily by callus formation. While potentially offering a rapid return to sport for some athletes, these nails are axially and rotationally less stable than plate fixation and significantly weaker biomechanically. They are generally not suitable for highly comminuted fractures and usually require removal once the fracture has healed.
Beyond the initial healing phase, what are the long-term complications clinicians should be vigilant for with clavicle fractures, especially non-union and malunion? How do these complications impact an athlete's function and potentially their career?
Long-term complications are indeed a significant concern, especially for high-demand individuals like athletes. While historically believed to be low, the non-union rate for displaced midshaft clavicle fractures treated non-operatively is now recognized as being significant, around 15.1% in some meta-analyses, compared to just 2.2% in operatively treated fractures.
And the risk factors are displacement, age.
Yes, risk factors for non-union include increasing age, female sex, initial shortening greater than 2 centimeters, complete fracture displacement, smoking, and significant comminution. Non-union typically results from a failure of mechanical stability, too much movement at the fracture site, which prevents the conversion of soft callus to hard bone. Management of an established non-union requires achieving rigid fixation, usually with plate fixation, and often providing biological stimulation, for example through judate decortication, drilling the medullary canals, or adding bone graft. Plate fixation offers reliable results with high union rates for non-unions.
What about malunion, healing in the wrong position?
Malunion, or healing with significant shortening or angulation, was previously considered primarily a cosmetic concern with good functional tolerance. However, more recent patient-reported outcome measures clearly show that significant malunions can cause persistent pain, a subjective loss of strength, rapid fatigability during overhead activities, and cosmetic concerns.
How does it affect the biomechanics?
The biomechanical consequences are quite profound. Shortening and rotational deformity of the clavicle's lever arm lead to a relative scapular protraction, altering the orientation of the glenoid and potentially causing scapular winging or abnormal scapulothoracic rhythm. This can decrease the resting tension of the shoulder girdle muscles, alter the force balance around the shoulder, leading to perceived weakness and decreased endurance, particularly affecting overhead activities which are critical for many athletes. Malunion has also been linked to symptomatic arthrosis, developing later at the AC and SC joints, and sometimes neurovascular problems or thoracic outlet syndrome due to bony encroachment on the brachial plexus or subclavian vessels. This could be especially profound in overhead athletes.
Can Malunion be treated?
Treatment for symptomatic malunion typically starts with targeted physiotherapy focusing on scapular control and strengthening. If symptoms persist despite this, surgical corrective osteotomy, essentially re-breaking the bone, restoring its length and alignment, and fixing it with a plate, can be considered after thorough preoperative planning, often involving CT scans and potentially 3D modeling.
What about fractures at the ends of the clavicle?
Briefly, lateral third fractures near the AC joint are classified based on their relationship to the acromioclavicular ligaments. Displacement occurs if these ligaments are torn, leading to high non-union rates, perhaps 22–44% non-operatively for unstable types. Undisplaced fractures are treated non-operatively, while displaced, unstable fractures often require surgical intervention using various techniques like hook plates, distal clavicle plates, or CC ligament reconstruction augmentation. Medial third fractures near the SC joint are rare, less than 5% of clavicle fractures, and due to the strong surrounding ligamentous structures, rarely displace significantly. Most are treated conservatively. Displaced fractures require careful neurovascular assessment due to the close proximity of vital structures posteriorly. Expeditious reduction, potentially open, in a setting with vascular or thoracic surgical expertise available is crucial, if any compromise is evident. So pulling it all together for the high-performing athlete, when is surgical intervention truly indicated for a clavicle fracture to safeguard their career and functional longevity? It's a synthesis of all those factors. For young, high-demand athletes, particularly those whose sports demand repetitive or forceful overhead activity, non-union and significant malunion, especially 2-centimeter shortening, are generally poorly tolerated and can be career-limiting due to the functional deficits we discussed: pain, weakness, fatigue, altered mechanics. Therefore, for athletes presenting with significantly displaced, shortened, or segmental midshaft clavicle fractures, early operative fixation is often the preferred strategy. The goal here is to facilitate a predictable union, restore normal anatomy, and allow for an early, high-quality recovery, maximizing their chances of returning to peak performance and preserving their athletic careers. It's about minimizing the risk of those long-term complications. 5.2 pectoralis major ruptures, the powerlifter's scourge.
Okay, from bone to the sheer power of muscle. Let's turn our attention now to the pectoralis major. Ruptures of this muscle might seem a bit niche, perhaps, but they are absolutely critical injuries for power athletes, aren't they? What's the classic mechanism of injury here? What are the telltale clinical signs we need for accurate diagnosis? And how does early recognition influence management and outcomes?
Yes, pectoralis major, or PM, tendon ruptures predominantly occur in young adult males, typically between 20 and 40 years of age, who engage in strenuous physical activity. Most classically, these ruptures happen during the eccentric phase, the lowering phase of the bench press maneuver in weight training. This is when the muscle is eccentrically loaded while in extension and abduction.
So the muscle is lengthening under load.
Exactly. That's when it's most vulnerable.
Okay.
However, other high-demand activities, such as rugby tackling, wrestling, martial arts like jiu-jitsu, boxing, and gymnastics, have also been reported as causes. Importantly, there appears to be an association with the use of anabolic steroids. Animal studies suggest these substances can lead to alterations in collagen structure, making tendons potentially weaker or more brittle, and cause disproportionate increases in muscle strength relative to tendon strength, effectively lowering the stress required to cause a rupture.
Interesting. Can you remind us of the anatomy and function?
Certainly. The pectoralis major muscle comprises two main heads: a clavicular head, upper part, and a larger sternal head, lower part, arising from the rib cage, sternum, and external oblique aponeurosis. These heads merge laterally to form a broad, flat tendon that twists on itself and inserts into the lateral lip of the bicipital groove on the proximal humeral shaft. Functionally, the pectoralis major is a powerful adductor and internal rotator of the arm, with the clavicular head contributing to forward flexion. While it might not be essential for mundane daily activities, it is an absolute necessity for maximal power production in strenuous and sporting endeavors. As mentioned, the muscle is under maximum stress when eccentrically loaded in extension and abduction, and it's typically the lower sternal segments that tend to fail first in a predictable sequence, often tearing off the humerus.
How do patients usually present? Is it obvious?
Patients typically present early and can often recall the exact mechanism and time of injury quite vividly. They frequently describe hearing or feeling a distinct snap or pop at the time of rupture. However, despite this clear history, the diagnosis can sometimes still be missed initially, perhaps mistaken for a simple strain, leading to delayed presentation for specialist treatment.
What are the key signs on examination?
In the acute setting, physical examination usually reveals varying degrees of swelling and bruising, ecchymosis, over the upper arm and chest wall, often tracking down the arm. Crucially, in both acute and chronic settings, several pathognomonic features are usually evident when compared carefully to the contralateral uninjured side. There might be a visible or palpable defect, a dropped nipple sign on the affected side, a medially retracted pectoralis muscle belly, especially when contracting the muscle, and a noticeable loss of the sharp definition of the anterior axillary fold.
How can you accentuate these signs?
These features can often be accentuated by passively abducting the arm or, more effectively, with attempted resisted adduction or internal rotation, asking the patient to push their hand inwards against resistance. It's worth noting that partial tears may not present with all these signs so clearly, and acute swelling can sometimes obscure some findings, necessitating a high index of suspicion, especially with the typical history.
In imaging, is MRI the way to go?
While ultrasound can be a useful dynamic adjunct, particularly in experienced hands, magnetic resonance imaging, MRI, is generally considered the preferred imaging modality. MRI not only confirms the diagnosis, but provides vital information for surgical planning. It can show the precise location of the tear, tendon off bone, musculotendinous junction, or intramuscular, the degree of tendon retraction, the quality of the remaining tissue, and the presence of any intact portions of the tendon in partial tears. It is important, however, to specifically request a dedicated MRI sequence that visualizes the entire pectoralis major muscle and tendon, as a standard shoulder MRI sequence focusing only on the glenohumeral joint might miss the injury or not show its full extent.
So what's the optimal management for these tears in athletes? Is surgery usually recommended? And what are the long-term prospects for them getting back to sport and regaining their pre-injury power levels?
The key factors determining the most appropriate management and the subsequent outcome really are the patient's age and activity level, the chronicity of the injury, how long ago it happened, and the precise location and extent of the tear along the muscle tendon unit.
Who gets non-operative treatment?
Non-operative management is primarily reserved for frail, elderly patients with a very sedentary lifestyle, or perhaps for very partial tears with minimal symptoms in lower demand individuals. It often results in acceptable functional outcomes in this specific low-demand population.
But for athletes?
For young, active, and high-demand patients, which includes virtually all competitive athletes, surgical repair is unequivocally the treatment of choice. This consistently yields the best long-term outcomes and demonstrably superior functional results, particularly regarding strength and power, compared to non-operative treatment. The best outcomes with the highest chance of restoring near-normal anatomy and function are achieved with early direct surgical repair, preferably within the first few weeks of injury, before significant tendon retraction and scarring occur.
Can surgery still be done later if the diagnosis was missed?
Yes, surgery can still be considered and often yields good results, even in selected cases where diagnosis has been delayed, or even in long-standing chronic cases, particularly if the athlete has a significant functional deficit or ongoing pain. A direct repair back to the bone is usually possible using various fixation techniques, including suture anchors, cortical buttons, or transosseous sutures through drill holes in the humerus. Currently, no single technique has been clearly shown to be definitively superior to others. In chronic settings where direct repair is impossible due to excessive retraction or poor tissue quality, additional releases or grafting techniques using allograft or autograft tendon may be employed to bridge the gap.
What's the rehab like after surgery?
Post-operative rehabilitation involves an initial period of rest and protection, typically in a sling, often for 3 to 6 weeks, depending on the repair security. Active hand, wrist, and elbow exercises are usually allowed immediately. Early, controlled passive or active-assisted range of motion for the shoulder is often initiated within a safe range determined at surgery, with movements like external rotation and abduction generally avoided or limited initially to protect the repair. The sling is gradually weaned off, followed by a structured progression aimed at restoring active motion, then strength, and finally power.
And the return to sport.
Return to sports and unrestricted activity, including heavy lifting and contact, is usually achieved somewhere between 3 to 6 months from the time of surgery, though some protocols might extend this further for maximal strength activities. High return to sport rates are generally reported after successful surgical repair, underscoring the effectiveness of this approach for maintaining an athletic career that relies on upper body power.
Okay, moving beyond acute injuries now, let's consider the long game. The cumulative, relentless toll of high-level sport can, unfortunately, lead to degenerative conditions like glenohumeral arthritis. This can be absolutely devastating for an athlete's career, potentially ending it prematurely. How exactly does arthritis tend to develop in this unique, high-demand population? And what are the often subtle diagnostic clues that clinicians might inadvertently miss, possibly leading to delayed treatment?
Chondral damage or damage to the articular cartilage in any major joint can be devastating for an athlete, varying from isolated, minimally symptomatic lesions to fulminant end-stage bipolar arthritis that's severe damage on both the humeral head and glenoid surfaces. It is certainly a common cause for premature retirement from sport. For athletes, the primary aim of management when arthritis develops is generally to maximize function and performance while prolonging their careers for as long as safely possible.
Is it the same type of arthritis we see in the general older population?
Not usually. When we look at the etiology, primary osteoarthritis, the wear and tear type with no obvious preceding cause, while it certainly occurs in older, lower demand individuals, is actually relatively rare in younger, high-level athletes. Its precise etiology in this specific group remains somewhat unclear. Interestingly, rotator cuff tears are uncommon in primary glenohumeral arthritis, unlike in the hip or knee. Secondary arthritis, however, is the predominant form we see in the athletic population. This stems from symptomatic chondral damage that occurs secondary to other problems, particularly trauma, and most commonly acute or recurrent instability.
So instability is a big risk factor.
A huge risk factor. Patients who have suffered even a single shoulder dislocation have up to a 20 times greater risk of developing glenohumeral arthritis later in life compared to the general population. Repetitive overhead activities, like those in the dominant arms of tennis players or throwing athletes, often lead to conditions like internal impingement, which is associated with occult or hidden chondral trauma that can predispose to arthritis over time. Other less common causes include osteonecrosis, avascular necrosis, osteochondritis dissecans, or the sequelae of previous joint infection.
Is there any risk from treatments themselves?
Yes, a critical, albeit rare, iatrogenic cause that needs mentioning is chondrolysis rapid cartilage destruction. There was a strong association identified, particularly during the 2000s, with the use of intra-articular pain infusion pumps, delivering continuous local anesthetic, especially bupivacaine, after arthroscopic surgery. This led to fulminant chondrolysis and devastating extensive glenohumeral arthritis developing in young patients within months of their index procedure.
But not from single injections.
It is crucial to note that this association has not been clearly established with standard single-shot injections of local anesthetic, which are commonly and safely used. Heightened awareness of the risks associated with continuous infusion pumps should hopefully significantly reduce any future incidence of this catastrophic complication.
How do we diagnose arthritis in athletes? You mentioned subtle clues.
Yes, diagnosis requires clinicians to be particularly astute because the signs and symptoms can indeed be understated or nonspecific initially. The athlete with early glenohumeral arthritis may present with complaints that demand careful diagnostic assessment to pinpoint the underlying cause. There's a real risk of narrowly focusing on more common shoulder pathologies, often seen in athletes, things like partial thickness, rotator cuff tears, biceps tendinopathy, subacromial bursitis, or labral tears, which can potentially delay the diagnosis and appropriate management of the underlying chondral damage, significantly impacting the athlete's career trajectory.
So we need to think beyond the usual suspects.
Exactly. It's crucial to actively elicit those understated symptoms, perhaps subtle episodes of instability they might downplay, or just a slightly reduced ability to undertake previously performed tasks at their usual intensity or duration. Classic symptoms of more established arthritis include night pain, often described as a deep ache associated with inability to sleep on the affected side, and mechanical symptoms like clicking, grinding, or even transient locking with sudden sharp pain that limits activity. We must also emphasize that athletes may be functionally disabled by symptoms that wouldn't necessarily significantly affect the average member of the public. They often continue to play and function at a high level, but report a gradual deterioration in their capability to perform at their expected peak level. That subtle decline can be the first sign.
What about the physical exam?
Physical examination findings to look for include periscapular muscle wasting due to disuse or pain inhibition, and crepitus during movement, which may be audible or just palpable by the examiner. The joint line itself may be painful on palpation, with posterior joint line tenderness often cited as a more specific, though not definitive, sign of underlying chondral damage. Range of motion restriction, particularly a loss of external rotation, both active and passive, and a painful arc of motion are also common findings.
And imaging, how useful is MRI here?
For imaging, standard radiographs are the essential initial investigation. AP radiographs are used to describe the degree of arthritis reliably using classifications like the Samuelson and Pareto classification, which categorizes patients into mild, moderate, and severe based on osteophyte size, glenohumeral joint space narrowing, and surface irregularity. While MRI and CT scans also play a role, their limitations in this context are key. Chondral surfaces in the glenohumeral joint are much thinner, around 1.5 millimeters on average compared to the knee, which can be up to 10 millimeters. This makes visualizing subtle early chondral lesions challenging. Magnetic resonance imaging, MRI, scanning for arthritis, even with specialized cartilage sequences or EVR arthrography, actually lacks sensitivity and specificity for detecting these subtle early chondral lesions reliably. However, a more profound full-thickness chondral loss is more easily evident. Computed tomography CT scans are particularly helpful for quantifying glenoid bone loss or wear patterns, especially if there are metal artifacts from previous surgery obscuring MRI, and 2D, 3D reconstructions can assist with exact localization of osteophytes or loose bodies.
So if imaging is limited for early stages, what's the gold standard?
Due to these inherent limitations of non-invasive imaging modalities in accurately diagnosing subtle chondral damage, diagnostic arthroscopy unfortunately remains the gold standard for definitive diagnosis and staging, particularly in joints like the shoulder, with inherently thinner articular cartilage layers. It allows direct visualization and probing of the cartilage surfaces. 6.2 Management strategies. Career-focused approaches.
When we approach the management of an athlete grappling with glenohumeral arthritis, the objective, as you said, isn't merely to reduce pain, it's intricately woven with preserving their career, if possible. How do we strategically stratify treatment options? What are the specific nuances within each category, ranging from maintaining function to salvaging what's possible and ultimately facing those difficult career-ending decisions?
This really requires a truly athlete-centered approach, because the principles and goals of managing glenohumeral arthritis in athletes are fundamentally different from those in the general older patient population. The professional athlete's primary aim is generally to maintain a career at the highest possible level for as long as possible, whereas recreational athletes may accept modifying their activities or lowering their participation level. Therefore, a solid understanding and appropriate management of the patient's specific aims, goals, and expectations are absolutely critical to achieving a positive outcome in this challenging degenerative condition. Athletes must be educated about their condition, taught how to interpret their symptoms, and actively participate in their management plan. Treatment options can be broadly categorized as palliative, reparative, restorative, and reconstructive.
Let's start with options aiming to maintain their career.
Okay, career-maintaining options are generally appropriate for athletes with early or moderate stage arthritis who are aiming to continue performing at the highest possible level. The objective here is to mitigate symptoms that limit high-level function. These options are generally less invasive with lower morbidity and often achieve successful short to medium-term outcomes, though the underlying natural history of arthritis will ultimately determine longer-term career impacts. For professional athletes, awareness of the World Anti-Doping Agency WADA code regarding allowed medications is, of course, essential.
What does non-operative management involve here?
First-line therapy includes activity modification, which might mean adjusting training load or technique rather than stopping completely, and the use of appropriate non-steroidal anti-inflammatory drugs, NSAIs, to decrease inflammation and improve function within WADA limits if applicable.
What about injections? Steroids, PRP?
Injections, such as corticosteroids, hyaluronic acid, viscosupplementation, and platelet-rich plasma, PRP, can potentially provide short-term pain relief and can also act as a diagnostic tool, confirming the joint as the pain source. Crucially, injections must be performed under sterile conditions, ideally with fluoroscopic or ultrasound guidance to ensure accurate intra-articular placement. And perhaps most importantly, injections should never be used simply as short-term solutions to get an athlete through a game or competition. This approach can have devastating consequences by masking pain, the body's protective mechanism, potentially leading to accelerated chondral degeneration. Corticosteroids themselves can also suppress collagen synthesis.
So what is the goal of injections then?
The objective should be to provide temporary dampening of synovitis and pain to allow the athlete to engage more effectively in a structured strengthening and rehabilitation program, not to enable an immediate return to high-impact activity while the joint is still inflamed or unstable.
And physiotherapy? Still core.
Physiotherapy forms the absolute core of non-operative treatment. It must be individualized and sport job specific, focusing on pain reduction, maintenance of range of motion, especially combating capsular contracture, and targeted strengthening. As arthritic shoulders often develop associated scapular dyskinesis, a tailored program focusing on scapular stabilization and regaining excellent scapulohumeral rhythm is paramount. This should be combined with isometric strengthening and passive stretching. Hydrotherapy can also play a key role due to water's buoyancy and resistance properties.
What if non-operative measures aren't enough? Arthroscopy?
Yes, in patients with earlier stage disease who fail conservative measures, arthroscopic debridement and chondroplasty can be considered. This involves smoothing down unstable chondral flaps or frayed cartilage, which are thought to be pain generators. Best outcomes are generally seen in patients with congruent joints, meaning the joint surfaces still match reasonably well, minimal osteophyte or cyst formation, and relatively shallow lesions, less than 2 centimeters squared, affecting only one side of the joint, usually the humeral head. Adjunctive procedures performed at the time of arthroscopy can include lavage, washing out debris and inflammatory mediators, and removal of loose bodies. As the disease progresses, anterior capsule contracture can develop, leading to decreased external rotation and increased load on the posterior chondral surfaces. More comprehensive arthroscopic procedures for advanced disease might include a full capsular release, subacromial decompression if needed, glenohumeral chondroplasty, AC joint excision, humeral osteoplasty, reshaping bone spurs, osteophyte resection, biceps tenodesis if the biceps tendon is involved, and even axillary nerve neurolysis if nerve irritation is suspected.
Some promising results have shown these more comprehensive arthroscopic approaches, sometimes termed comprehensive arthroscopic management or CAM, can potentially delay the need for arthroplasty by up to 2 years in around 85% of selected patients.
What about options when things are more severe? Career salvaging options.
These options come into play when career-maintaining strategies are becoming less successful or for more severe or symptomatic degenerative disease. While high-impact activity might still be possible after some of these, the overall success rates in a high-load athletic environment are certainly more circumspect. Athletes' expectations must be carefully managed, as they may not recover sufficient function or symptom control to return to their desired pre-injury level.
What procedures fall into this category?
Microfracture is one. The principle, borrowed from knee surgery, is to penetrate the subchondral bone plate to stimulate a healing response from the bone marrow, leading to fibrocartilage formation over the defect. It requires meticulous surgical technique and a very slow, tailored rehabilitation protocol involving restricted weight bearing or loading. While successful in the knee for certain lesions, the literature supporting its use in the shoulder is minimal. Best outcomes, anecdotally, are reported for smaller, isolated humeral side lesions in young, active patients. A potential advantage is that it doesn't appear to compromise future reconstructive options like arthroplasty.
What about grafting, like cartilage transplants?
Chondral or osteochondral grafting techniques are designed for more focal chondral lesions. Modalities include osteochondral allograft transplantation, using donor tissue, primary autograft transfer, OATS procedure, taking plugs from a non-weight-bearing area, staged autologous chondrocyte implantation, ACI, growing the patient's own cartilage cells in a lab and reimplanting them, or the use of synthetic scaffolds to encourage cartilage regrowth. Osteochondral grafting for humeral head defects has theoretical advantages, but can have significant donor site morbidity if using autograft or availability issues with allograft. Reports specifically in the shoulder athlete population are limited.
Biological resurfacing? What's that?
This involves resurfacing an arthritic glenoid surface, using biological tissues instead of a plastic component. Tissues used have included infolded anterior capsule, allografts like fascia lata or Achilles tendon, or commercially available dermal tissue matrices or biologic patches. It's designed as a potential bone-preserving alternative to prosthetic glenoid replacement, particularly in younger patients. It's typically an open procedure requiring prolonged rehabilitation, although advanced arthroscopic techniques are developing. Sporadic reports looking specifically at athletes show some good outcomes in the first couple of years, but long-term durability is still under investigation.
And joint fusion, arthrodesis. Seems drastic.
Arthrodesis, or surgical fusion of the glenohumeral joint, has largely been consigned to historical significance for primary glenohumeral arthritis by the success of prosthetic implants. It's now mainly reserved for situations like failed arthroplasty, deep infection, or certain neurological injuries. However, it holds a unique, albeit small, niche place for a very specific subgroup of athletes. Despite creating a fused, immobile glenohumeral joint, a successfully united arthrodesis does allow patients to return to almost any desired level of sport, including full impact and heavy loading, as there are no implant-related restrictions or concerns about wear or loosening. Thus, for certain patients, perhaps those involved in heavy manual labor or specific high-impact sports, especially on their non-dominant side who prioritize the ability to perform high-impact or loading activities over achieving a functional range of motion, arthrodesis should potentially be discussed as an alternative to arthroplasty. It's a trade-off between motion and unrestricted activity.
Finally, the career-ending options.
Yes, inevitably, sometimes the damage is too extensive or symptoms too severe for career preservation. Activity modification, meaning the complete cessation of the specific sporting activities that exacerbate pain, is often the first line of management advised in many patients with advanced arthritis. But for a professional or serious recreational athlete, this is often the last resort, and, by definition, a career-ending decision regarding that sport. This difficult decision is typically made due to intractable pain significantly affecting quality of life, stiffness severely limiting function and performance, or the realization, often after failed attempts at salvaging procedures, that continued high-level sporting activity will significantly compromise their long-term joint health and overall quality of life.
And joint replacement, arthroplasty.
Glenohumeral arthroplasty, or joint replacement, provides the most consistently positive and reproducible outcomes for pain relief and functional improvement in older patients with advanced arthritis. Modern implants and techniques are excellent. Options include hemiarthroplasty, replacing only the humeral head, sometimes with reaming of the glenoid, the ream and run technique, or total shoulder arthroplasty, replacing both surfaces. Cementless resurfacing arthroplasty is another option that aims to preserve bone stock and potentially offer easier revision surgery later, which is a consideration in younger patients. While short and medium-term results of arthroplasty are generally positive even for younger active patients compared to their preoperative state, this must be weighed against the generally superior overall results and longer implant survival, typically seen with stem total shoulder arthroplasty in older populations. Crucially, however, for the professional or high-level recreational athlete, prosthetic arthroplasty is realistically only an option following the end of their competitive career. A prosthetic joint simply cannot tolerate the high forces, repetitive impacts, and extreme ranges of motion required by the vast majority of upper limb athletic pursuits without risking early failure, loosening, or fracture. It demands significant, permanent activity adjustment and is, by definition, a career-ending decision for these athletes regarding high-impact or high-demand sports.
Finally, let's talk about the ultimate objective for any injured athlete, achieving a safe, effective, and hopefully sustainable return to play. What are the core evidence-based principles guiding modern rehabilitation after shoulder injury or surgery? And crucially, how do we objectively measure readiness, moving beyond just a patient feeling better to making truly robust, data-driven decisions about their return?
This is absolutely where the science of recovery comes in, moving beyond just letting nature take its course. Effective rehabilitation extends far beyond simple pain management and reduction of inflammation, though those are important initial steps. It must encompass the meticulous restoration of optimal muscle strength and balance around the shoulder girdle, achieving functional joint range of motion specific to the athlete's needs, and crucially, a carefully managed progression to functional movements that precisely replicate the demands of the athlete's specific sport. This entire progression, from early protection to high-level function, is underpinned by a fundamental requirement for meticulous joint control. This necessitates explicit attention to restoring proprioceptive awareness, ensuring dynamic stabilization from the rotator cuff and scapular muscles, developing feed-forward mechanisms through anticipatory muscle responses before movement occurs, and training reactive muscle function to cope with unexpected perturbations during athletic activity.
So it's much more than just strength and flexibility.
Much more. And return-to-play decisions, therefore, absolutely must be based on objective measurements and criteria, not just time elapsed or subjective feeling. This involves a thorough evaluation of the athlete's overall health status, a clear assessment of the remaining participation risk of re-injury or further damage, and consideration of extrinsic factors like equipment, playing surface, or game intensity. McCarty and colleagues outlined what might be considered ideal criteria for return to play following shoulder stabilization surgery, which provide a good framework. Little or no pain, the patient's subjective impression of stability, feeling confident in the shoulder, near normal range of motion compared to the other side, near normal strength, often defined as 90% of the contralateral side, demonstrated normal functional ability in sport-specific tests, and execution of normal sport-specific skills without deficit or compensation.
And the kinetic chain comes back into play here.
Indispensably so. The kinetic chain concept is fundamental to effective rehabilitation, especially for overhead athletes. Remember, it's that open-link system of segments, lower limbs, torso, scapula, GH joint, upper limb operating in a proximal to distal sequence to generate and transfer high velocity or force to the distal segment, the hand. The final velocity or force achieved depends on the contribution of each segment and the smooth interaction between them. Therefore, when assessing and rehabilitating the overhead athlete, each segment of the kinetic chain needs to be assessed to ensure it possesses the required range of movement and muscular control. Any break or inefficiency in that chain will overload another segment, often the shoulder. The scapula, as we've discussed, plays that pivotal role as a critical link, permitting effective force transfer from the trunk and legs and ensuring optimal glenohumeral joint alignment. This highlights the paramount need to identify and include correction of any suboptimal movement strategies elsewhere in the kinetic chain within the shoulder rehabilitation process. Fixing the shoulder in isolation often isn't enough.
You also mentioned an alternating pattern of mobility and stability.
Yes, that's a crucial concept within the kinetic chain, often attributed to physical therapists like Gray Cook and Michael Boyle. It suggests that optimal performance requires a balance between stability and mobility at different joints, often following an alternating pattern up the body. For example, the ankle needs mobility, the knee requires stability, the hip needs mobility, the lumbar spine needs stability, the thoracic spine requires mobility, the scapula needs stability as a platform, and the glenohumeral joint itself needs mobility. Dysfunction often occurs when a joint that should be mobile becomes stiff, forcing the adjacent joint that should be stable to compensate with excessive movement, leading to injury.
That makes sense. Are there specific screening tools for this?
Integrating these components leads to the use of specific screening tools designed to assess these different segments. Examples commonly used include tests for thoracic rotation, like the locked lumbar rotation test, thoracic extension, example combined elevation test, shoulder internal and external rotation range, assessing GIRD and total arc, hip internal and external rotation, and tests for core trunk endurance, like extensor, lateral, and flexor endurance tests. These help identify limitations throughout the chain.
One of the most talked about concepts in athlete rehab, particularly for throwers, is glenohumeral internal rotation deficit, or GIRD, which you touched on earlier. Can you explain precisely what it is again, why it matters as a potential injury risk factor, and how we should measure it accurately in a clinical setting?
Yes, glenohumeral internal rotation deficit, or GIRD, is a very common adaptive change observed specifically in overhead athletes, particularly throwers. It is characterized by a functional increase in glenohumeral external rotation on the dominant throwing side, coupled with a compensatory decrease in internal rotation on that same side. The total arc of rotational motion might remain similar side to side, but the arc itself is shifted posteriorly. The underlying mechanism is often thought to be adaptive tightness or contracture of the posterior-inferior glenohumeral ligament PIGHL complex and the postero-inferior capsule, developed over time due to repetitive throwing motions. This tightness can lead to a posterior-superior shift of the point of glenohumeral articulation and the center of rotation during throwing.
Why is this potentially problematic?
From a clinical significance standpoint, increasing GRD, specifically a significant loss of internal rotation compared to the non-dominant side or compared to the total arc, may be associated with an increased injury risk in throwing athletes. It's thought to contribute to conditions like internal impingement and SLAP tears by altering joint mechanics.
How do we measure it reliably?
We assess GIRD relative to the total arc of motion of the glenohumeral joint. Total arc measured glenohumeral internal rotation plus measured glenohumeral external rotation. It's crucial to measure this accurately, usually with the patient supine, the shoulder abducted to 90 degrees, and the scapula stabilized by the examiner or an assistant to prevent scapulothoracic motion compensating for true glenohumeral rotation loss. It has been proposed that a healthy shoulder should ideally present with around 180-degree total arc of motion, or perhaps more functionally relevant, the total arc of motion should be roughly equal bilaterally, within 5-10 degrees.
Are there specific thresholds for concern?
While there's ongoing debate and research, generally accepted thresholds for concern often include a side-to-side difference of greater than 20 degrees for internal rotation loss, or a loss of total rotational range of motion greater than 5-10% compared to the contralateral side. These values are often considered potentially pathological and warrant intervention like targeted stretching. More specific predictive findings for injury risk have been proposed in certain populations, such as a loss of greater than 25 degrees into internal rotation in baseball players, or a loss of 20 degrees internal rotation combined with a 5% loss in total ROM, doubling the risk for injury in professional baseball pitchers in one study. However, it's important to acknowledge that some studies have not found a direct or consistent association between GRD measurements alone and subsequent injury. So while GRD is an important factor to assess and address particularly significant deficits, it should be considered as part of the broader clinical picture on kinetic chain assessment, not as an isolated risk factor. 7.2 Objective Strength and Proprioception Assessment.
Beyond range of motion measures like GID, accurately assessing shoulder strength and proprioception is absolutely crucial for making those safe return-to-play decisions. How do we get truly objective, reliable data on these parameters? How do we move beyond just subjective clinical impressions, feel strong, given the known limitations of traditional methods like manual muscle testing?
That's a vital question for evidence-based practice. When it comes to shoulder strength assessment, while standard manual muscle testing, MMT, using the Euro 5 Oxford scale, has good clinical utility for detecting gross weakness, it is inherently highly subjective. MMT is significantly prone to user error and bias, especially at the higher grades, grade 4 and 5, where distinguishing subtle but potentially clinically significant weakness can be very difficult. It's often hard to present objective, quantifiable data using this method, and the results can be heavily influenced by the examiner's own experience and strength relative to the patient.
So what's a better alternative for objective data?
We strongly advocate for the use of handheld dynamometers, HHD, as a much more objective and reliable method of strength evaluation. It's far superior to MMT for quantifying strength, and crucially for evaluating subtle changes in muscle strength caused by injury, dysfunction, or rehabilitation progress. HHD provides objective numerical data, for example, in kilograms or pounds of force, that can be tracked over time and compared to the contralateral side or normative data. It's particularly useful for assessing specific scapular stabilizer muscles, like the upper middle and lower trapezius and the serratus anterior, by resisting specific movements in standardized test positions.
What about endurance, not just peak strength?
Beyond peak strength, assessing muscular endurance is also incredibly important, especially in athletes performing repetitive tasks. Shoulder muscle fatigue has been proposed to be strongly associated with repeated arm use and the subsequent development of rotator cuff disorders and instability. The mechanism for this is postulated to be due to fatigue causing altered timing and coordination of the local muscle system around the shoulder girdle. Fatigued muscles absorb less energy before elongation, increasing the risk of tissue strain and injury during subsequent forceful movements. Endurance can be assessed using time tests or repetitions against submaximal resistance.
Okay, and proprioception, that sense of joint position. How do we measure that objectively?
Proprioception assessment is equally important, but perhaps even more challenging to quantify reliably in a standard clinical setting. We define proprioception as a sensory afferent feedback mechanism that mediates joint position and movement sensibility with muscular reflex stabilization. Essentially, it's the body's kinesthetic sense knowing where your joint is in space without looking. Why does it matter? Well, those mechanoreceptors within the capsule-labral complex around the shoulder, which detect joint position and movement, can be damaged due to local tissue trauma from injury or surgery. This can lead to significant deficiencies in joint proprioception. Reduced joint proprioception has been proposed as a significant contributing factor to functional instability and re-injury, as the joint doesn't know where it is as accurately, impairing protective muscle responses.
How can we test it clinically without expensive equipment?
While many high-tech laboratory devices exist, like isokinetic dynamometry with proprioceptive modes or electronic motion tracking devices, these are often costly and impractical for routine clinical use. However, we can advocate for more utilitarian, clinically applicable methods. The assessment of proprioception using reproduction of passive positioning is a valid and established method. This often involves joint angular replication tests. Typically, the examiner passively places the patient's injured shoulder into a specific angle or position. The patient consciously registers this position, often with eyes closed. The arm is returned to the resting start position, and the subject is then asked to actively replicate the test position as accurately as possible. The difference between the target angle and the reproduced angle is measured. This assesses the function of both static joint receptors and dynamic muscle spindles, shoulder joint stabilizers, and their input to position sense.
Other practical open and closed kinetic chain exercises used in rehabilitation also challenge proprioception, such as attempting to hold a specific joint angle with eyes closed, or contralateral limb mirroring exercises where the patient tries to mirror the position or movement of their uninjured arm with their injured arm while keeping their eyes closed. These practical methods provide valuable clinical insights into an athlete's proprioceptive capabilities and help guide rehabilitation. 7.3 Conclusion of Rehab Principles. So, to synthesize all of that, effective rehabilitation for the athletic shoulder demands a truly profound understanding of sport-specific biomechanics and the demands placed on the joint. It requires a comprehensive biomechanical screening process, looking beyond the shoulder itself to assess the entire kinetic chain for any contributing deficits. We must utilize objective measurement tools for tracking progress in strength, endurance, range of motion, and proprioception. And fundamentally, there must be a commitment to a criterion-based, milestone-driven progression through rehabilitation phases, rather than relying on rigid, time-based protocols that don't account for individual variation in healing and response. This integrated, objective, and holistic approach is absolutely essential to guide a safe, effective, and sustainable return to play, ultimately protecting an athlete's career and their long-term joint health.
This has been an incredibly comprehensive deep dive, truly unraveling the immense complexity of the shoulder. We've journeyed from its intricate anatomy and biomechanics right through to the diverse injury patterns seen in both overhead and contact athletes, and explored the nuanced, constantly evolving landscape of diagnosis and treatment. I feel we've moved far beyond a superficial understanding today, providing a framework for truly informed clinical decisions when faced with these challenging injuries.
Indeed. And I think if there's one key takeaway for orthopedic professionals listening, it's that a deep understanding of the shoulder's interconnectedness, its role within the entire kinetic chain, is not just academic. It is absolutely paramount for effective practice.
Because it allows for more precise diagnoses.
Precisely. It helps identify those often missed contributing factors, like subtle scapular dyskinesis or seemingly minor bony changes that can have major downstream effects. And ultimately, it leads to the implementation of more effective, targeted, and often career-preserving interventions that truly address the unique demands and biomechanics of each individual athlete.
It allows for more precise diagnoses. The identification of often missed contributing factors like scapular dyskinesis or subtle bony changes, and the implementation of more effective, career-preserving interventions that truly address the unique demands of each athlete.
Absolutely. Perhaps the biggest challenge for us as clinicians moving forward isn't just treating the injury we see on the scan or find in theater. It's about truly understanding and interpreting the unique athletic blueprint of each individual patient. That incredibly delicate balance of their innate constitutional factors like laxity, the acquired adaptations they've developed through years of sport, and their specific kinetic chain movement patterns. How do we continue to refine our ability to read that complex blueprint, not just so we can react effectively to injury, but so we can proactively support our athletes, manage their load, and guide them through the long, demanding arc of their careers and, importantly, beyond, into a healthy, active life afterwards?
A powerful thought to consider indeed. How do we read that blueprint better? Thank you. If you found this deep dive insightful and valuable, please do take a moment to rate and share our deep dive with a colleague who might also benefit from these crucial insights. Professor Moimam, thank you so much for sharing your profound expertise and invaluable contributions to this incredibly detailed discussion today.
It's been my pleasure. Thank you for having me.
And to you, our listener, thank you for joining us on The Deep Dive. We encourage you to continue your own deep dives into knowledge. Until next time.